Always wanted to do this. It's what it's here for. It's what it's here for. Well, not always, but. Okay, good afternoon. I feel like it's morning. Okay. Good afternoon, everybody. I think we have everybody here. Okay, let me, this is the meeting of the Public Outreach, Education, and Wellness Committee of the Medical Board of California. So I want to first go over the ground rules. I know you've all heard these, the script before, but I'm going to read it again.
Move the mic away from your face, please.
Oh,
Move it away.
is that better?
Yes, thank you.
Such an echo in here.
That's good.
Okay, so here you go for the script. I want to ask all of you to please turn off your cell phones to silent or make sure they're off the table to avoid any feedback noise on our calls. You may notice board and committee members assessing their laptops during the meeting. They're using the laptops solely to access the board meeting materials that are in our electronic format, since we try to do paperless. This is an official meeting of the Medical Board of California, and as such, disruptions of the board's business will not be tolerated. We have a designated time on the agenda for public comment and ask for public comment on each agenda item. I ask that you be respectful of the need of the board to conduct business, and should anyone disrupt the meeting, I will ask that person to conduct himself or herself in such a manner that permits the board to transact its business. Excuse me. This meeting will be available via teleconference, and individuals listening to the meeting will have an opportunity to provide public comment and will be assisted by our teleconference moderator, who will be facilitating that process. For those members of the public participating via the teleconference, please wait until that moderator has introduced you before you make your comments. And also the volume of your, in the background needs to be turned down to avoid feedback. To request to make a comment during the public comment period, press the *1, and you will hear a tone indicating that you are in the queue for comment. If you change your mind and do not wish to make a comment, go ahead and press #, and that cancels out the queue. Assistance is available throughout the teleconference meeting, and to request such assistance, press *0. Now, each person will be limited to 3 minutes for each agenda item. However, during the agenda item 2, which is public comment on items not on the agenda, the board has limited the public comment period for those individuals on the teleconference to 20 minutes. In addition, the public comment from individuals here at the meeting will also be limited to a total of 20 minutes. Thereafter 20 minutes, no further comments will be accepted. During public comment on any other agenda item, 10 minutes will be allowed from comments from individuals on the teleconference as well as those in this audience. And after 10 minutes, no further comments will be accepted. The business services staff here will be assisting me with receiving public comments via teleconference during this meeting. I'm almost done. The board welcomes public comment on any agenda item, and it board's intent to ask for public comment prior to the board taking action on any agenda item. If for some reason I forget, I'm remiss in calling upon you for public comment, please, and you wish to speak, please raise your hand and I will recognize you. I would like to request that all speakers please complete a presenter slip so I can call you by name at the appropriate time, and a record is made at this meeting that can be full and complete. However, this is completely voluntary. Please give the speaker slips to Mrs. Simoes. Right? Right there? Okay. And I will do my best to call upon everyone who has supplied such a slip for the agenda item and recognize also those who wish to make a last-minute comment. I want to remind the speakers, please stay on the topic of the agenda item listed and keep your comments to 3 minutes or less. And we will have a timekeeping device, so when it goes yellow, please then try to summarize your comments prior to your expiration of your time. Thank you very much. Now we call roll of the committee members.
Dr. Hawkins?
Here.
Dr. Kraus?
Present.
Dr. Levine?
Here.
Ms. Pines?
Here.
Mr. Saronasul? Ms. Yaroslavsky?
Present.
Dr. Lewis?
Present.
Thank you. We have a quorum.
We have a quorum. Thank you. So, the second item on the agenda is public comments not on the agenda. Is there anybody wishing to make a public comment in this agenda item?
Do you have slips there?
Well, I have slips. I
Number
just
two.
don't know.
That's
I
the
gotta,
number two.
wait a minute, let me sort them.
I'll do it.
I'm just trying to sort them. Hold on, this one doesn't have one. Four, 5, 4, 5. Now I have two that are not labeled. I have from Genevieve Clairvaux, and I have, do you wish to make a comment on this agenda item?
This is for something.
Okay. Good afternoon.
Geneviève Claverol. I was kind of concerned of that little speech you gave just before the meeting, because at lunch you had a program on civility, and that's a big issue, and I think you are a wonderful board. You allow people to speak all the time, and it seems that to have that little speech before prevent civility. And I think that's one thing we're having a lot of problem now. When you have a lack of civility, even impact the quality of diagnosis. And actually, I've done a lot of research on that lately, and I'd be more than glad to send it to you. But I am very concerned that at many of the meetings, not only yours, but the Board of Supervisors and so on, people are admonished to behave appropriately. And I think most people do. And I think to have that little speech don't help, that's all.
Thank you. Any comments, anybody else in the audience wishing to make comment on the agenda item number 2? Do we have any comments on the phone?
Amber, are there any callers?
No callers at this time.
Okay, no more comments on the phone. If not, let's move to our next agenda item. Next agenda item number 3 is approval of minutes from the July 30th, 2015 Education and Wellness Committee meeting.
So moved.
Second.
Second, okay. Should we,
We have discussion on that.
any discussion on the minutes? Any discussion from anybody, the committee members? No? Any discussion from anybody in the audience on agenda item number 3? None? And anybody on the phone wishing to make a comment on agenda item number 3? Do we have anybody?
Amber, any callers on the phone?
No one on the phone.
None? Okay, Ms. Smoes, please call the roll.
Dr. Hawkins?
Here.
This is to approve the minutes from the last meeting.
Yes.
Dr. Kraus?
Aye.
Dr. Levine?
Aye.
Ms. Pines?
Aye.
Mr. Saronasul? Ms. Yaroslavsky?
Aye.
Dr. Lewis?
Aye.
Thank you.
Okay, agenda item number 4. This is the presentation, discussion, and possible action of elements of the successful physician health program Ms. Kirchmeier and Ms. Robinson, please come forward. Thank you.
Great. Good afternoon, Chair and members. Please turn to pages EDU 4-1 through EDU 4-23 for the PowerPoint presentation on elements of a successful physician health program. You may recall that I presented information on physician health programs at our July board meeting. At that same meeting, we had presentations from both the Colorado and Arizona programs. Board members expressed interest in continuing the discussion and asked staff to solicit feedback from interested parties. As you know, the board has not had a formal program since the diversion program was sunsetted in 2008. Board staff met with consumer groups and also with physicians groups to hear their recommendations for a successful physician health program. This PowerPoint presentation contains information on uniform standards, medical board staff recommendations, as well as consumer group and physician group recommendations and concerns. The purpose of this presentation is to provide information and discuss what elements are necessary in a physician health program in order for it to assist physicians with substance abuse problems while still meeting the board's mission of consumer protection. Any physician health program would need to comply with the uniform standards for substance abusing physicians and will require regulatory changes. As a way of background, 2008 SB 1441 Ridley Thomas created the Substance Abuse Coordination Committee charged with formulating uniform and specific standards that each healing arts board must use in dealing with substance abusing licensees, whether or not a board chooses to have a formal program. Currently, there are 16 standards. I will now go over some of them. Standard 2 specifies as requirements for temporary removal of the licensee from practice while undergoing a clinical diagnostic evaluation and specific criteria that must be met before permitting the return to practice on a full-time or part-time basis. The licensee must cease practice during the evaluation pending the results and review by board staff. While awaiting the results of the evaluation, the licensee shall be randomly drug tested at least twice per week and shall not return to practice until he or she has at least 30 days of negative drug tests. Standard 4 governs all aspects of required testing, which specifies the licensee can be drug tested at any time, with the minimum range for the number of random tests to be between 36 and 104 per year, depending on certain factors. It requires observed collection of specimens, and prior to vacation or absence, alternative drug testing locations must be approved by the board. Standard 6 states specific standards used in determining whether inpatient, outpatient, or other type of treatment is necessary. Standard 8 deals with the procedures to be followed when a licensee tests positive for a banned substance. The licensee must cease practice, and the board will contact the licensee and instruct him or her to leave work. The board will also notify the licensee's employer and work site monitor, if any, that the licensee may not work. Standard 9 specifies procedures to be followed when a licensee is confirmed to have ingested a banned substance. For instance, when a board confirms that a positive test is evident of use of a prohibited substance, the licensee has committed a major violation as defined, and consequences shall be imposed. Standard 10 specifies consequences for major and minor violations. In particular, it considers the use of a deferred prosecution stipulation in which the licensee admits to self-abuse of drugs or alcohol and surrenders his or her license. That agreement is deferred until or unless the licensee commits a major violation, in which case it is revived and the license is surrendered. Standard 13 provides that if a board uses a private sector vendor that provides services, that vendor must have standards for immediate reporting to the board, any and all non-compliance by providers or contractors that provide services, such as specimen collectors, group meeting facilitators, and worksite monitors. They must also have standards to approve and discontinue the use of providers or contractors that fail to provide effective or timely services. And also standards for the licensee's termination from the program and referral to enforcement. Standard 14 states that if using a vendor to provide services, the board shall disclose the following information to the public for licensees who are participating in a board monitoring program, regardless of whether the licensee is a self-referral or a board referral. However, the disclosure shall not contain information that restrictions are a result of the licensee participating in a program. It must include the licensee's name, whether the licensee's practice is restricted or the license is on inactive status, and provide a detailed description of any restrictions imposed. Standard 15 specifies that if a vendor is to provide services, an external independent audit must be conducted every 3 years by a qualified independent reviewer or review team from outside the department with no real or apparent conflict of interest with the vendor providing the monitoring services. On a side note, the board thinks that there should be some type of repercussion to the vendor for a failed audit. Standard 16 provides there must be measurable criteria and standards to determine whether each board's method of dealing with substance abuse in licensees protects patients from harm and is effective in assisting its licensees in recovering from substance abuse in the long term. The board must use the following criteria to determine if its program protects patients from harm and is effective in assisting in recovery. All licensees who either enter a program or whose license was placed on probation as a result of a substance abuse problem successfully completed either the program or the probation, or had his or her license to practice medicine revoked, surrendered, or placed on probation in a timely manner based on non-compliance with the program. And at least 75% of licensees who successfully completed a program or probation did not have any substantiated complaints related to the substance abuse for at least 5 years after completion.
And I just want to point out that the reason we went over these is because we need you to understand that we believe that any, first of all, because they're in Senate Bill 1441, which means they were part of the uniform standards, but because we want the members to understand these were the ones that were, during the process, had brought up some issues and from different groups, and so we wanted to make sure that everyone knew that any program that we would support would make sure that they adhere to each one of these uniform standards. So unlike some of the boards right now who have diversion programs, and now these standards are coming in, if there was a program that was proposed, we would want this to actually be in from the get-go, right from the beginning, and it would require us to do some regulations. So that's why we wanted to go over those in depth, so you understand that there's a lot of safety measures and around those uniform standards.
I will now go through the board staff recommendations.
Before we go on, and I appreciate your going through this, I think it's helpful for all of us to remind ourselves of this. I had a question about the purpose, and I don't remember our deciding that if we were to have a physician health program, that its sole purpose would be to assist physicians with substance abuse problems. I
guess that was kind of our thought behind a physician health program, that it would be doing that, but while enabling us to also meet our mission of consumer protection. And really, it's more to monitor, I would say, the individuals.
So again, I mean, my thought all along has been, when we use the term physician health, and it would encompass physicians with substance abuse problems, but would also be open and available to assist physicians with other issues that were they not addressed, had the potential to impair their function as physicians. The selection of the term health suggests something broader. And I understand that
I see what you're saying.
that
Okay.
this purpose piece relates to whatever elements relate to a substance abusing physicians. But I'm just questioning whether we have said that is all that a physician health program would.
So actually, we'll get to that, because one of our board staff recommendations is that it is only for substance abuse issues. I think that you're possibly thinking it would also be for mental illness, or maybe disruptive physicians or things like that. And I think sometimes those are hard to monitor, but that is what's before the board. Again, when we go through these, I'm kind of superseding Letitia, it's okay, but I
Okay.
wanted to let you know that from our perspective, that was our thought, but when we go through the board staff recommendations, we want to hear from the board as well. And if you want to put other items in that, then that's fine for us, we would just put them in the, whatever you determine at the end. But from our perspective, we really wanted to focus on substance abusing licensees.
Dr. Kraus?
I agree with some of the concerns expressed by Dr. Levine. And indeed, when I've spoken to the issue before of a physician's health program, one of the things in my own community that I highlighted as representative of a need for that were 3 physicians in short time who had committed suicide. And to my knowledge, none of them had a substance abuse issue. But there are things about the practice of medicine that causes physicians, more so than any other profession, to hide their problems for fear of having their business or practice infringed upon. Certainly substance abuse is high up on the list, but a physician who's suffering from depression will also hide that. And I think that we should not begin to use the term synonymously of physician health program and a substance abuse problem. So I would encourage the staff, if possible, to find some way semantically of separating those terms so we don't confuse them in the future, because I think there's a need for both.
And that's what we'll put in our recommendations when we get to them.
Okay, so board staff recommends the program should not reside within the board. It should be run by a private, contracted, nonprofit entity. It should have adequate protocols for the board's communication, for the program's communication with the board, and have regularly scheduled meetings. The program should allow for both self-referral and probationers to participate. Report to the board any physician who is terminated from the program for any reason. There shall be no diversion. If a complaint is received, the enforcement process will be followed. There should be clear and regular communication to the board on the status of probationers in the program, and participants should share in the cost of administering the program. If the required audit finds the program is not in compliance, there must be repercussions. There must be sufficient resources to perform clinical roles and case management roles with sufficient expertise and experience, not to exceed 50 physicians per case manager. The program should only be provided to substance abuse and licensees. This was our original recommendation based on what we discussed before. And strict documentation of monitoring is necessary. The following are some recommendations and concerns from the Consumers Group, which ask the question, is there a need for a program? And recommended an analysis be done to determine if there is a need for a program.
So before we get a little bit more into the consumer groups, I want to just explain our process when we went through this to put these together. And if I'm duplicating, I'm sorry. But we actually, as board staff, we sat down, and first of all, we looked at the uniform standards, and then we looked at some of the other information literature that Ms. Robinson had found. And then we actually met with each group. We met with the consumers groups, and we met with the licensee groups. And then the board staff recommendations are what we culled from all of the information that we got from those two groups. The items that are in your slides for the consumer group and for the professional groups, the licensee groups, are things that were outside of those. So things that we either didn't want to opine from and we wanted to hear from the board on them, or things that we didn't believe should be an element of a physician health program. So as we go through these, what we're asking you is to look at these and make a determination whether you think that they should be in a recommendation, because at the end of all of this, what we would like is to have a motion that any legislation that is moving forward would have the elements of what you have put together. And obviously, you're going to make the recommendation to the full board when we meet this afternoon. But that's kind of what we're looking for here as we go through the consumer and the licensee side. Is there anything that needs to be added in? And if we didn't take it exactly as the group had provided it to us, we did put it in each of their slides. So as Letitia goes through these, we're not going to go through each one because you've all had a chance to read them, but the ones that we really wanted to point out that you need to kind of look at as the committee.
Okay, so I think the last one I have for the consumer groups is, under certain circumstances, termination from the program should trigger revocation of the license. Some of the physician group recommendations were, they felt that there should be an education and promotion of awareness of the program with information for hospitals, training programs, and medical groups about how to identify potential impairment, services available, policies and procedures, what to expect from the program, how to contact it, how to enter it, how to refer to it, and how to use it. They also felt the program should have adequate, stable funding, primarily from license fees, with additional funds from other sources, such as fees from participants, and that immunity from liability for those who function for the program. This concludes my report of elements of a successful physician health program. Now we'll turn it over to Kim.
And as you can see there were a lot of different recommendations that came out from each group. And so now we'd actually like to open it up to you to see if there's anything, kind of like Dr. Levine has already kicked us off in discussing, things that we have missed, things that you see in the recommendations from other group that we should add to our recommendations as a board to go forward, and then to answer any questions that you might have.
Mrs. Yaroslavsky, please.
So, excuse me, I have a couple questions. First of all, you asked consumer groups and you asked staff groups. I'm just wondering if there's any room to ask those providers of such programs if there are weaknesses or strengths that they see that to include within our regulations that might be helpful.
Absolutely, and just so you know, the licensee group that we met with were made up of not only licensees, but individuals who have these programs and that run these programs. So that was also involved in our licensee group. We had, I'm going to probably miss a bunch of them, but they were definitely there at the table, and they gave us a lot of really good input.
So the other thing I want to know is that as far as record keeping goes, when a licensee enters a program, there's records that are maintained. How long, when the licensee finishes the program, will records need to be maintained, and for how long, and is that part of a process?
That would be part of the process. I'm going to actually look to Ms. Robinson to see how long they were kept in the diversion when we had a prior program. So we'd have to have some record retention, and that would be set up in the administration of that vendor when they set that up. I'm not sure. We can also look at other state agencies and see how long they keep those records at that facility for those individuals. And obviously, if there was a successful completion and it was a self-referral, that would be nothing that then was reported. The medical board would never have access to that because they'd be a self-referral in the program. And if they successfully completed in the amount of time that was required, then we would never have those records.
Right, okay.
Dr. Levine?
Yeah, so I guess I think I now understand where I might have been misreading this. And if what you're saying, and I think this is correct, is that this would establish the baseline for what has to be in a piece of legislation
Yes.
for a program, I'm going to leave the name aside, that addresses the issue of substance abusing licensees, that these elements would have to be in there. Whether the program went beyond that would not be addressed by this.
Right.
A legislator
Right.
could choose to do that, and what the board is focusing on is the specific issues of what needs to be in place to meet the requirements of the uniform standards and to meet the requirements of consumer protection in regards to substance abusing licensees.
Right.
And I'm fine with that. And my only hope would be that we not attach the name health
Okay.
to that, because I do think we have an interest in a concern for a broader set of issues to maintain a high-quality, healthy practitioner inventory, if you will, in California. And I would hope that any legislative effort to create such a program would go beyond the substance abusing physician licensees, but understand now what the intention of this is.
But I do think that if this board feels strongly about that, I think we should put that in as an element, because it's not just for substance abusing licensees if you want it to be more. So for example, in the physician group recommendations, there was one that recommended that it follow, and I can't find it right now, but it was that it follows the National Physician Health Program recommendations. Is it on the next page?
Very last
Yeah.
point. Second.
And the reason we put it in this slide rather than actually over in the board staff recommendations was because part of the recommendations and part of the standards that they have, they do take mental health individuals into the statewide physician health program. So if that's something that the board wants to do, a lot of these will fit into that category, because you'd still have probably clinical diagnostic evaluation and some other monitoring that individual would have. And so that's not something we're opposed to if the board feels strongly about that.
Ms. Yaroslavsky, go ahead.
So just,
Oh,
I mean,
finish.
my sense is that there are many physicians for whom, knowing that there's a place they can call, or a website, or a contact they can make to get help, referral to some source of help, a triage function, whatever, whether or not the issue is a substance abuse issue, that it would be an incredibly useful thing. And again, may be tangential to this, but
Right. It was interesting, if I remember back to our old program, and again, I'll look to Ms. Robinson because she's much more experienced with it. If I remember right, a lot of the individuals who we had that were in our prior program with mental health issues also had substance abuse issues. They kind of ran hand in hand, if I remember right. I'm not saying that if a mental health person has a substance abuse, but it seemed that they came together a lot.
I just forgot one thing I wanted to ask you, and that was that within this floor that we're setting a bar at, that we're just saying that if any of our doctors go to a program, that we're like putting a stamp of approval on these programs, or we're not putting a stamp? Because if a doctor were to go to a program that's not given some kind of a stamp, and they are successful, that's their choice too, isn't it?
That is their choice, and they have that choice today. I think I'd like you to look at the board staff recommendations on this, similar to what Dr. Kraus has actually brought up as our policy compendium. that we would look at this and that any future legislation that were to come before the board seeking any type of a physician health program, whatever that looks like, that we would have something that we could look back at and say the committee and the board supports a program that would have these elements in it. And that's kind of what we were looking for today.
Sorry, thank you.
Right. Dr. Kraus?
I commend the board staff for the work product and work effort. There are three ways of doing things, my way, your way, and the right way. And as I keep rereading the consumer group recommendations and the physician group recommendations and the board staff recommendations, I'm wondering if you could help me figure out where the firm lines in the sand are, because I know not everyone will be satisfied.
We couldn't agree more by trying to put the board staff recommendations together. We really weighed, and I'll just walk through a couple just so you understand where we were coming from, and I'm sure there's going to be a ton of public comment, so I hope I don't step on anybody's toes when I talk about this. And I don't want to talk out of turn because we did have the groups there with us, and they'll come up and talk. But for example, the one big push about an analysis that needs to be completed to define if there is a program. We believe that is something that may or may not need to be done, but we believe that needs to be done as part of the legislation moving forward. If the legislator wants to take that on, he's going to have to deal with consumer groups coming forward to him, and he's going to have that. So that should be outside of the board. That's why we didn't put that in. The penalty, let's see, for the program, there's another one in here that was a tough one for us, and it's that you would terminate if there were issues with the program, with the vendor, in an audit, that we would immediately terminate the program. Now, while that sounds like the right thing to do, you have who knows how many, 100, 200, 300 individuals in the program. To immediately terminate them, that might not be the appropriate thing. And in some audits, obviously, there's the possibility for improvement. And so we think that there should be repercussions to an audit where there were some negative findings, but we don't know that the best thing for physicians or for the public as well would be to immediately terminate that program and leave all of these individuals without an ability to be in a program. So where that fine line in the sand is probably going to be with any legislation that goes forward and what gets battled out in that arena, quite frankly.
Dr. Hawkins, did you have a comment?
Just that we want physicians who want to step forward and get help to do that, and just some acknowledgement that we have to develop a program that invites them, but at the same time doesn't put them in, even though we have to protect the public, it doesn't actually put them in a position where they're just less likely to come forward.
And that is one of the consumers group's concerns, is that if you attach it to the board, you might not get individuals that actually want to join into that program. And that was one thing we did hear from those groups. So,
any other comments from members of the committee? If not, I'm going to go to the public comment of those individuals that are here in the room first. And I apologize, I'm just taking them as they came up, presented to me, and I hope I don't mispronounce anybody's name, but I might. The first one I have is Karen Mioto. Up to the public speakers table there on your right.
I commend the effort of the board, and as the chair of a medical staff well-being committee, I can't stress more the importance of addressing the mental health issues and finding an avenue where that can be dealt with, because, as Dr. Kraus said, physicians feel very stigmatized by these issues, so I think it's so important in addition to the substance abuse issues. Thank you.
Thank you for your comment. And just remind the speakers, please state your name clearly, and if you'd like your affiliation, at least your names. The next speaker I have is...
Just a reminder that that is voluntary.
It is all voluntary. Yes, it's all voluntary. I have Greg, I think it's Skipper. Did I get that right? Yeah. Oh, good. Okay, thanks.
Thank you. Was I supposed to push a button or anything? No. Oh, it started by itself. Okay, so I'm Dr. Skipper. I am a board-certified internist and board-certified in addiction medicine, and I run the Promises Professionals Evaluation and Treatment Program in Santa Monica, California. And I've worked in addiction medicine for about 30-plus years. And during that time, I ran the physician health program for the Alabama Medical Board for 12 years prior to moving out to California a few years ago. So I've had a lot of experience in this area and have been involved in developing some of this, and I was at the meeting that the board invited us to. Thank you. I just wanted to point out one thing that caught my eye was under the purpose. It sort of implies that helping physicians is in conflict with protecting consumers. You know, sort of it says, while still meeting the board's mission of consumer protection. And I contend that helping physicians in itself can help, patients. It helps protect patients. So I don't think we need to see them as either or. I think early intervention, getting help for physicians, having a healthier physician workforce helps patients. So there's no conflict. Another thing I wanted to point out is that there was a recommendation that the program, if it's created, have adequate professional staff. I certainly think that's totally appropriate. I think the program should have medical leadership by a physician and/or physicians. That we should have, in this iteration, if it comes to pass, MDs involved to be part of the program and part of the leadership to better, communicate with the medical board and committees of the board. And I also want to make mention that having this program, unlike some of the other programs for other health professional boards, I think an emphasis should be on education and early detection and intervention, and rather than on just monitoring and probation, because you can have anybody sort of monitor people. I think the biggest helpful function to the public for public protection is having a way for example, hospitals to contact somebody and get some help with a colleague and sort of help them decide, should there be an intervention, how should it be done, and what should happen after that. So on the front end, I think we need a program that really educates and helps do early intervention, and rather than just worry about the monitoring part, which seems to be kind of the obsession of a lot of the previous programs and so forth. Anyway, thank you.
Thank you for your comment. The next speaker is Edward Barrera.
Hi, my name is Edward Barrera. I'm with Consumer Watchdog. I'll try to keep my comments focused because I know there's other people here who are who know much more about this more in depthly than I do. But at the very least, first of all, we're not sure if you should be creating a program. But for us, any guiding principle for any program should be transparency, accountability, and independence. At a previous board meeting, you had some doctors from Arizona and Colorado testify about their state's programs to confidentially treat substance abusing doctors. Well, California's already had that for years. It allowed doctors caught using drugs to choose a confidential rehab program to avoid discipline. That was ended by the board because it became a revolving door for drunk and high physicians that prioritized keeping a doctor's addiction confidential over protecting patients. Medical boards should not sanction any program that lets doctors keep their addiction problems secret and avoid consequences when they fail. Once again, we're not sure if the board should be creating a program, but if they do, these need to be included. Patient safety should always trump physician confidentiality. Any complaint of possible substance abuse problems should be made a priority, and any enforcement should be handled expeditiously. If a patient is harmed, enforcement and disciplinary actions must happen. It should not ever be connected to the California Medical Association or anyone connected to previous diversion programs, and it also needs to be independent of this board. Thank you.
Thank you. The next speaker is Julie D'Angelo-Felmuth.
Good afternoon, Dr. Lewis, members. Julie D'Angelo-Felmuth from the Center for Public Interest Law. Excuse me, and I'm the former Medical Board Enforcement Monitor. As you know, this board had a diversion program for 27 years for substance abusing physicians, and after that program failed 5 performance audits, including one that I did in 2004, this board unanimously voted to terminate that program in 2007. Since then, physician organizations have attempted on many occasions to create a new program, some kind of program for substance abusing doctors. Each such program would be funded primarily by licensing fees collected by this board. Each of those attempts were different. Each of them failed. I would actively discourage you from going down this road again. You should learn from the history. There is no need for a new program. There are literally thousands of programs, treatment and monitoring programs in California and all over the United States, and nothing prevents any doctor from self-referring into one of them today. Also, the effectiveness of these programs has never been proven. No program tracks participants after they leave the program. Having said that, I'll tell you the elements we've insisted on since 2007. First, obviously, the program must strictly comply with the uniform standards. Second, doctors should not be able to participate in a medical board-funded program secretly. That's completely contrary to your mission. Only doctors who are on probation should be able to participate in any new program. Third, any and all program noncompliance should be reported to your enforcement program immediately. Fourth, a detailed program description and fiscal analysis must be prepared by the proponents. That has never been done, not even for the original prior program. Sixth, any new program must be audited by the Bureau of State Audits every 3 years, and if it is not performing well, it should be ended. Finally, under no circumstances should a new program be directed or controlled by the same organizations or individuals who were part of the liaison committee that oversaw this board's prior program. That has been attempted in the past. That is a non-starter for us. For many reasons, you should not go down this road again. You have other options. If you really think there's an insufficient number of private programs out there, or that they're not available in some locations, then look at that, study that, document that. If you think physicians need a referral to a good program, then task yourselves with coming up with standards and criteria for treatment and monitoring programs, and evaluate programs based on those criteria, and post a list of the good ones. If you think physicians don't go to treatment or monitoring programs because they can't afford them, and some physicians cannot, then create some kind of scholarship fund, perhaps with voluntary contributions, to help physicians who are truly intent on recovery go to a program. You should look into sources of funding other than physician licensing fees. But please don't think that your creation of a state-funded, state-subsidized program will lure in the many thousands of physicians who statistically have substance abuse problems. There were very few true self-referrals in your prior program. Because doctors knew they would probably relapse, they didn't want to come to a program connected to the medical board. That same thing will happen again.
Please conclude.
So, thank you. I encourage you to explore these other options. There is no need for you to create a new program. Thank you.
Thank you, Ms. Felmuth. Next speaker I have is Dr. Tracy Zemansky.
Hi, I'm Dr. Tracy Zemansky. I'm the current president of Pacific Assistance Group. We have 15 locations throughout California where we work privately with physicians who are in recovery. Most of us worked with physicians in recovery before the program was sunsetted by the medical board. I strongly support the board efforts to encourage physician wellness on every level. Any program that will be effective in preventing patient harm must have an early intervention and a self-referral option that is confidential and viable. Early intervention allows physicians who already find it quite difficult and challenging to ask for help to seek care before problems develop, which is the absolutely best way to ensure patient safety. As our excellent lunchtime speaker said, it is more effective to support positive values and action and be proactive than to correct a negative problem and be reactive. I strongly believe that patient safety equals physician early intervention and confidentiality, and support the medical board in developing and supporting a program. Thank you.
Thank you very much. Next speaker I have is William Coltern.
Howdy. I'm a physician and a diversion graduate of 16 years ago. And I am here to advocate for the redevelopment of diversion, which at a personal level certainly was very active in helping me direct my own life towards getting into recovery and staying in recovery successfully. And the one point that I wanted to make was, at least in my own experience, was that there are differences in programs, and that there are programs out there that that can and do have special programs for healthcare providers that more than adequately can work with physicians during that recovery period. And it's because of diversion in 1999 when I was in diversion that I was directed by the diversion board to programs that were very specifically aligned with impaired physicians. And I think it certainly contributed to my recovery and continued recovery. Thank you.
Thank you very much. The next speaker is Robert Herbst.
I'm Robert Herbst, a retired recovering ophthalmologist. And I don't know what you should do. I'm the last person who would know what you should do. But I am in favor of, and I'm happy to hear that the board is at least considering a board-supported recovery program for physicians. Or not a recovery program, but a health maintenance program, if you will. And the uniform standards are fairly rigorous. The things that, what I found is the previous health program that was discontinued helped me do things that I wouldn't do myself. They were the ones that introduced me to means of handling my problem, and they provided the monitoring, and that was a very definite necessity for me because I was self-willed, and I think monitoring is an important part of this. But the other emphasis I think that would be helpful would be, again, education at the hospital level for the well-being committees, and the fact that the board sends out an action letter every month. I think that at least in some of those there should be prominent, and maybe there already is, but if there were a program, prominent that should education what that program is, where it is, and make it easy to find so that these physicians know where to go. And as for me, I probably wouldn't be here today if it weren't for the past program, and I was very sorry to see it go out of existence. But thank you for allowing me to speak.
Thank you for your comments. The next speaker I have is Michelle Montserrat Ramos.
Good afternoon. My name is Michelle Montserrat Ramos. I'm here on behalf of Consumers Union Safe Patient Project. I first became familiar with this issue in 2007 when the failed, now terminated, confidential physician diversion program was up for sunset review. You may ask, why would such a confidential program be of interest to me? Well, my fiance, Lloyd Montserrat, died at the hands of a cocaine-addicted physician. Lloyd was a California political leader whose life was taken at 36 years old because his path crossed with a physician who had a problem with crack cocaine and had earned a long arrest record, all while he held a license to practice medicine in California. You see, I should have known that Lloyd's doctor had a drug problem, a long arrest record, and a long list of victims. That information should have been available to me when I checked Lloyd's doctor's profile before Lloyd entered the hospital. But guess what? That information was not available. Why was this information not available? Because there was a confidential program in place which allowed doctors to practice with issues with drugs and alcohol, and Lloyd, I, and California consumers were not allowed to know. We did not have the right to know that these physicians had such drug and alcohol problems. So Lloyd died, dead, at 36, and Lloyd's doctor continues to practice. You call that consumer protection? I think not, and most Californians would agree with me. I stand here to tell you that we will not support any kind of program that is confidential. Kim was quoted this week stating that the medical board wants you to be an informed patient. In order for us to be informed patients, you cannot support any confidential programs of any kind. There is no way that we will support any program that is confidential. Our lives matter. Rehabilitation of the physician cannot come before Californians' lives. We took steps in 2007 to change that. Information on drug-addicted and alcohol-impaired physicians that the board is made aware of is now available to the public. Your predecessors terminated a confidential program stating to hide something from consumers, something so blatant, it's unconscionable today. How could each of you think that somehow it is the right thing to do now to hide something so unconscionable from consumers? The uniform standards have only been fully adopted and placed into regulations for 3 months now. It took fighting you years to get you to follow the law and place these standards into regulations. In dealing with substance abusing physicians, you must make the implementation of the uniform standards your top priority. You must give the uniform standards time to work before putting in place any new system that might interfere with them. There is nothing now preventing doctors from seeking such treatment with complete confidentiality. There is no need to create a special program that may interfere with oversight responsibilities of the board. As your physician predecessor stated...
Please conclude. You're well over.
Okay. The public now demands transparency. Why should doctors be protected in secrecy when consumer safety hangs in the balance? Again, it is time to now protect consumers. Our lives matter. No more confidential programs of any fashion under any name. Thank you.
Thank you. Next speaker I have is Yvonne Chung.
Good afternoon. My name is Yvonne Chung with the California Medical Association. CMA appreciates the board's efforts to study this important issue and bring forward input and comment from all stakeholders. we support the development of a statewide physician health program. California is currently one of a handful of states that does not have a physician health program. And physicians are one of the few licensed health professionals in California that do not have access to this type of statewide health program. We believe that the establishment of a physician health program is consistent with the board's mission of public protection and will increase patient safety by ensuring that impacted physicians are receiving coordinated treatment and monitoring services and that their recovery is appropriately supervised. Such a program should also encourage education, early intervention, and encourage physicians to address issues before they rise to the level of impacting patient care. We believe the physician health program principles developed by your staff provide an excellent starting point for the development of a robust and comprehensive program that will enhance the board's ability to protect patients and rehabilitate physicians to return them to safe and active practice. We urge your adoption of these recommendations and look forward to continuing to work with the board on this issue. Thank you.
Thank you. The next speaker is Genevieve Clavel. You pass? Okay. The next speaker is Bruce Olmscheid.
Thank you. My name is Dr. Bruce Olmscheid. I'm a family physician in private practice in Los Angeles. I frequently see patients with substance abuse issues. In addition, as a physician in recovery myself, I am occasionally, I guess perhaps rarely, approached by colleagues seeking advice or suggestions about where they can seek help for themselves or for colleagues, very much aware of their fears and concerns about needing to access a program where they can seek early intervention and help without the ramifications that were addressed that can affect their livelihood and practice. I fully support the board's efforts to put a formal physician health program in place and hope that it is a program that physicians will feel safe to access. I respectfully ask the board to give additional considerations to the ramifications of requiring public disclosure of the names of any physician, I didn't say that correctly, of any physician, all physicians who are receiving services and doing well through a monitoring program. A program that does have confidentiality where appropriate, with public disclosure where appropriate, will foster self-referral at the same time continuing to provide protection to consumers. A program that allows for confidential reporting to the board will allow the board to administer a program that effectively monitors physicians who are receiving treatment for substance abuse and doing well, at the same time providing protection for consumers. Thank you.
Thank you for your comments. The next speaker is Mr. Dwayne Rogers.
Good afternoon, Chairman and members of the committee. My name is Dr. Dwayne Rogers. I am a licensed psychotherapist, and I am the Pacific Assistance Group Area Administrator in San Diego County. I have 43 years of experience in substance abuse and 33 years experience in monitoring licensed health professionals. I fully support your efforts to develop a strong and accountable physician health program. I believe California deserves such a program and that licensed physicians in California deserve this program. I have monitored physicians and other licensed health professionals since 1982 and continue today to monitor licensed health professionals from the 6 other boards. I have personally monitored over 590 physicians and health professionals in support groups over that time and have found that with early intervention and monitoring, physicians in recovery enhance the quality of their patient care. I am aware of 2 studies, one in 1991 and one in 1993, that found that physicians in a monitored program had a lower incidence of license complaints than the average licensed physician in the state. The concept of not monitoring at-risk physicians through random and observed urine tests weekly support group meetings, case management oversight, and site monitor reporting is dangerous itself. I have monitored physicians in both state and private programs. I find that a strong structure with leverage, support, and monitoring can, in either case, provide a safe environment for physicians to seek help before more severe problems develop. This is a more effective alternative than enforcement only. I would like to just say in support of a strong program with early intervention and self-referrals that my first diversion group in 1982 had 9 older male late-stage alcoholics and drug addicts. By 1980, the program and the group had a self-referral rate of 67%. I believe, my point is that I believe that a confidential physician health program can achieve high levels of self-referral rates and thus early intervention before serious problems occur. Thank you for this opportunity.
Thank you very much. Next speaker is Dr. Zucker.
Good afternoon. My name is Michael Sutcher, and it's a pleasure to be before you again. I was here in July speaking about the Arizona Medical Board's Physician Health Program, which I have been the medical director of for 23 years. I would like to tell you that we started out with substance abuse as the primary focus and co-occurring mental illness, but for the last 6 or 7 years, we cover every area of physician health. I also have been actively involved in physician health activities in California for about a decade, and we run a private evaluation and monitoring program called the California Physicians Health Program. And in addition to working with and advising this board and staff, we've also worked with many medical groups, hospitals, and individual physicians in the time we've been here. I do have to make a comment about the gentleman from Consumer Watchdog in Arizona. Every single physician in our program is known to the board, and in fact, we monitor agreements written with the board's agreements that we oversee and monitor. They also are required to notify hospitals, surgery centers, and all employers, and any other party who has a need to know. So there is no one in our program unknown to the medical board. I also want to make a comment about self-referrals. What's commonly called self-referrals in this business are generally not true in the context, oh, I think I have a problem, I'll go get help. Virtually everybody gets a shove from a family member, a colleague, law enforcement, the board, or other sources to get help. So it's not realistic to think that people will just go get help on their own. This board and a physician health program can play a key role in doing that. I do think, in echoing Dr. Skipper's thoughts, that we do need strong medical leadership. That was something that was seriously lacking in the prior diversion program. There was also a comment about what happens after 5 years. And record retention. We never throw our records away. We do get some people who come back, and it's nice to have those records 10 or 15 years later, because sometimes their memory of what happened isn't quite the same as what we recollect. And Dr. Skipper, Dr. DuPont, and McClellan, who wrote the original blueprint study that verifies the quality outcomes of a well-run physician health program, which was preceded by good treatment, are doing a research study nationally, which we are also participating in, on outcomes after 5 years, which preliminary data is extremely good. I would like to tell you I strongly support the effort you guys are undertaking. I agree with the staff recommendations that you heard today. I would comment that there's a comment that is a nonprofit has to be a nonprofit. I think it has to be well run, regardless of the business structure. And I believe it would vastly help the status of consumer protection and public protection, and you in fulfilling your role by doing this. I think this state has been left short in the last 9 years or 8 years since diversion closed.
Please continue.
And thank you very much.
Thank you very much. And the next speaker is Lisa McGiffert.
Good afternoon. My name is Lisa McGifford. I'm the director of the Consumers Union Safe Patient Project, and I'll try not to repeat, but we are among the people who believe that this program is not needed, and we strongly support the staff recommendation that if this program were to be set up, that there would be public information about physicians that were referred to this program because of probation. We do believe that physicians are probably among the people in our culture who have the most resources for getting treatment, and we support them to get treatment. But if they come to the attention of the board because of some problem, especially of harming patients, then that should be publicly, and the board decides to act on that, that should be public knowledge. You just heard somebody recommend that the hospitals should know, the insurers should know, the employers should know, but the very people who need to know, the patients, are not on that list, and we think that they should be able to see that. A couple of other things on the recommendations, one of them to report to the board any physician who is terminated for the program for any reason. We think that should be a notice to the board for any physician who has violated the terms of the program. And with regard to the audits, we also think if there's an audit, that the program fails the audit, that is, they show that they're not responding to violations of what the physician is supposed to be doing, that there should be repercussions, and we think they should be serious, that it should be terminated. If the audits are every 3 years, then as soon as there's an audit that shows that a program is not performing as it should be, then that contract, that no more physicians should be referred to that program. The board should find another program to take that on. And I think that's really warranted considering that the program in this state 5 times had a bad audit. That should never happen again. First bad audit, go find another program. Thank you very much.
Thank you for your comments. That is the last speaker for the public comment from the audience. Now I'd like to ask if there's any public comment on the telephone.
Yes, we do have 2 comments.
Okay. Go ahead.
Can you hear me?
We can hear you.
Okay. My name is Tina Manassian. I was a victim of a doctor who participated in the former diversion program run by the Medical Board of California. I wasn't his only victim. There are countless others that suffered and have passed away. In 2002, he performed a surgery on me that I was not a candidate for. 13 years later, I still suffer from the lingering effects of the surgery, with excruciating pain and spitting sutures. During that time, he was at his all-time high with his alcohol problem, and the medical board was trying to revoke his license, but I didn't know any of this. He was in a secret and dangerous program called diversion. The issue was he failed diversion twice, but they allowed him to continue to practice medicine. The diversion program was a monitoring program. When the medical board becomes aware of a substance abuse problem in a physician, they divert the physician into a program as opposed to take away his license. The idea is to get them into recovery, rehab them, and put them back into practice when he's safe to practice. And during that time period, they're supposed to monitor him, do random drug testing, attend group meetings, and have worksite monitors when they're permitted to return back to practice. They use a lot of monitoring mechanisms in that program in an attempt to monitor the physician's behavior. The problem is none of those monitoring mechanisms were effective at all. They were inadequate. The random drug testing was not random at all. It was done at many times on the days the physician could anticipate or manipulate. In my case, my doctor was allowed to have his own office manager, an employee of his, a person he can hire and fire to be his worksite monitor. She lied for him on his AA records, stating he attended meetings, when in fact he never did. And they tried to dilute his urine when he was being drug tested. The medical board's diversion program was a failed program. It was audited 5 times, and they failed all 5 audits. I will not support any kind of program that keeps doctors' substance abuse problem confidential from patients. Think about it. If it was your mother, father, brother, sister, daughter, son, grandchild? Would you allow them to be treated by a doctor who has a confidential substance abuse problem? Thank you.
Thank you for your comments. Is there anybody else on the telephone wishes to make a comment?
We will take our next one.
Okay, go ahead.
My name is Carol Moss. Can you hear me?
Maybe you need to speak up just a little bit or turn up the volume.
Okay.
Try again.
Okay. My name is Carol Moss, and I'm calling representing the public. Everyone believes that physicians, just like others, deserve care, and they deserve a chance to get better. But in this case, we know the California Medical Board has been unable to monitor and protect the public from harm with the diversion program, now called the Physician Health Program. No matter what you call it, the risk is far too great. If there is any kind of a health program, the public that we represent will not support this board managing confidential programs going forward. We know too many people that have been harmed. The risk is too great, and you will hear from many if you move forward with this proposal. Thank you.
Thank you for your comment. Do we have anybody else on the telephone?
Yes, we do.
Okay, we have somebody else. Go ahead.
Hi, this is Susan Shanese. Can you hear me okay?
Yes, we can hear you okay.
Thank you. I'm with Consumers Union Safe Patient Project and also Medical Error Transparency Plan. And I believe this is a conflict of interest to have any board physician or any member of the board that works with physicians, either directly or indirectly, vote on a diversion program of any type, with any title. And I would ask that you would remove yourself from this vote, as you cannot be impartial. I think this needs to be a public-only vote. Thank you for your time.
Thank you. Is there any other, anybody else on the telephone wishing to make comment?
Any other callers?
There are no further comments.
There are no further comments. Thank you. Have I failed to recognize anybody else in the audience here for public comment? Okay. Any comments from the board members?
I apologize. I have been sitting here listening to all of the public comments and to staff comments, and somewhere there has been a translation problem from English to English. We are sitting here with the opportunity of ensuring that whatever program is out there that exists is going to have certain criteria that is going to be helpful to protect the public and engage the people that are participatory. We're not here in any sense or fashion to create a program where doctors can go and use it to get help with substance abuse. So I think that the public needs to understand, and I just want to make sure I'm at the right meeting, because when I'm sitting here listening to everybody I've been listening to, I'm thinking, oh, well, we're starting a program, we're going to open the doors and start working. The uniform standards were adopted by every single health provider board in the state, except for this board. Wasn't it? Isn't that what happened in the back when, after diversion? Okay, then I apologize. So, but I just want to make sure that nobody sitting in this room assumes that we're going to be opening a program tomorrow, that the medical board is going to be running it and staffing it. Correct? Am I correct? I just make sure that we're all in the same place, because that's not what I was feeling. So I apologize for comments at the end, but I was starting to get nervous that we were going to be doing something that I was totally against.
Okay. Dr. Kraus, please.
May I move that our committee accept and endorse the board staff recommendations to be forwarded to the full board?
Do I have a second?
I'll second that.
Skrosowski is second. Any further discussion? Ms. Simoes, do you like to call the roll?
Sorry. Dr. Kraus?
Aye.
Dr. Levine?
Aye.
Ms. Pines?
Aye.
Ms. Yaroslavsky?
Aye.
Dr. Lewis?
Aye. The motion,
Just point of clarification that when the presentation is made to the full board, it be made with the clarity that this is not about the framework for the board to create a physician health program. It is to respond to work groups over a number of years that have asked the question, what would it take for a legislative proposal to be consistent with the board's needs for consumer protection. And this is staff's recommendations, having listened to that this, whether or not there is a legislative proposal or someone comes forward with one, that this is the beginning of that conversation.
correct, it's nothing to do with a legislative proposal. It's only if one was put forth by someone, this is what the framework that we would require suggests,
That we would
correct?
use to evaluate any legislative
Right.
proposal. Is that, I hope I'm
Kirschmeyer, that's
understanding.
correct. That's what I thought. I think we all have it. Okay, so the motion carries. Thank you. Okay. We have a next discussion is agenda item number 5. It's entitled Presentation and Discussion and Possible Action of a Verify a License Campaign and a Public Outreach Plan. And we have Ms. Kirschmeyer, Ms. Smoes, and Ms. Hawkins.
Yes, today, tomorrow.
We will try to be brief. I know we're short on time, but this is actually an item, as we go through, the main intention of providing the whole outreach plan for us is that to gain information from the board members if we're missing anything in this plan. So as I go through my items and as Ms. Simoes and Ms. Hawkinson do the same, we're really looking for you all to provide input and specific input of places where you'd like this changed, or specific input as to other groups you'd want us to reach out to along the path of this. So on pages EDU 5-1 to 5-4, you will find the board's Verify a License campaign outreach plan. I'd like to start actually by thanking Ms. Pines for her assistance with this plan, and she has actually provided some great insight to staff, and we want to thank her for all her guidance. As you can see in the plan, although the board will continue with its current outreach, it will also be driving a broader agenda with an end result of making March Verify a License Month. Board staff will continue with its outreach from now until March, including attending events such as health fairs, health-related walks, and outreach at malls. I would like to take a moment and let you know how successful our 2 mall outreach events have been. Last weekend, we were allowed to set up in the mall in Sacramento. This event was advertised in 10 media sources, including newspapers, business journals, the Capital Morning Report, and CBS News. Board staff handed out brochures on how to verify your physician's license and also had computers set up to walk individuals through the board's website to look up their physician. In addition, staff are currently, actually right now, I think, probably getting ready to leave, at Horton Plaza and will be at Fashion Valley Mall tomorrow. We've also had some press coverage on this event too. Due to the governor's travel restrictions, we are running these events with the board meeting in order to use the staff that will be at the meeting to host those events. I would like to point out that we still do have travel restrictions particular to outreach. Therefore, we will be using staff in our probation units located around the state, as well as reaching out to board members to assist us with events as time permits. And with that, I'm going to kick it off to Cassandra to talk a little bit about the advertising.
There's a number of avenues that we're looking to utilize for advertising. One is Pandora. Pandora Radio. We're looking at mass transit, RT, and the other mass transit bus places in Los Angeles and Bay Area and situations like that. Utility bills, looking at possibly putting some advertising in utility bills. Store receipts, many stores give you receipts, and on the back there's advertising. Billboards, jumbotrons. In fact, we're in discussion with Sacramento Kings with regards to that. Radio PSAs and television PSAs as well. And I'm going to turn it back over to Kim because most of these require a budget.
So while the board may actually have the funding for some of this advertising, all funds expended do have to be approved through the Department of Consumer Affairs. I've spoken with DCA executive staff and informed them of the importance of the board's outreach. However, we may be limited in what advertising will be approved for this plan. We were able to do, on another item that Cassandra had worked on for the prescribing PSA, we were able to expend funds for that, but we were kind of told that might be the end of our ability to do this. So this is something we will be having to talk to the Department of Consumer Affairs in order to get approval on those kind of advertising that costs money to do.
Okay, so I'm going to talk a little bit about the advertising that we've identified that is free. So this is something that we can do without DCA approval. So we've thought about, we've actually we've developed some posters that are similar to our brochures, and that we could place at places like pharmacies or places where consumers receive health care, schools, other government agencies, libraries, and other agencies where basically patients go. And we also want to talk to our sister state agencies about getting ads placed, like one possibility is on the employee pay stubs. And there's other agencies that actually do this now, that put advertisements on pay stubs. And we've also talked to some of the school districts about getting information in their electronic newsletters to parents. And we just have to kind of work with these other agencies to see what kind of advertisement placement we can get.
I'm going to talk about media distribution. I have a relationship with iHeartRadio. I did a radio show with them that was webcast on the prescription drug abuse and misuse issue, and I hope to go ahead and talk with them and schedule something with regards to Verify a license as well. I'm also looking to reach out to National Public Radio and Capital Public Radio, and of course I always reach out to other media outlets. We have had stories done here from 10 News as well as Channel 7, NBC News, which had actually come out to the mall yesterday and interviewed me and filmed what we were doing there with regards to reaching out to consumers. In addition, there is an article that I believe is coming out tomorrow through the San Francisco Chronicle, and they also came out to the mall in Sacramento with me, took some pictures, actually took a lot of pictures, kind of hung out with us for about an hour to see what we were doing there. So this is something in addition that we will be pushing and moving forward to as well, and creating activities and things that can draw media coverage.
So board staff will be working on products that can be used to promote the board. We've actually already developed a brochure which was actually approved by our editorial committee and printed by the Department of Consumer Affairs. Each of you have been provided with a copy of that brochure, I think. And in addition, DCA assisted in the development of posters based upon the brochure that the board can use. Board staff will be creating a PSA video that emphasizes the importance of checking the board's website to verify their physician is licensed and in good standing with the board, and a tutorial that walks the individuals through verifying a physician's license, as well as educates the individual on the board's documents and posting requirements. After the board meeting, these two items will be made a high priority. The board will need to work with the Department of Consumer Affairs to develop the PSA video, as we did with the prescribing video that we did. As you can see from the plan, there is a lot to be done. Board staff have thought about what needs to be done on the campaign, but we would like to know if the board has any suggestions for the plan or any questions.
Okay, I'd like to open up to members of the committee. Ms. Yaroslavsky first.
The other end if you want.
Oh, I started. Are you going to defer?
No, I'm.
To you? Okay.
Never miss an
Dr. Yield?
opportunity to miss an opportunity. I want to thank you for all the work that you've put into this. I just would hope that when you're looking at the big scale of the situation, we've got 30 million people or 25 million people in the state of California, and reaching them 100 at a time is not really as effective a use of time as might be. So that if you were to take a look at the large hanging fruit, elected officials all have newsletters. They've offered, when we did our day at the Capitol, they've all offered to do it. So if you have a targeted date that you're looking to have this done at, instead of piecemeal as it comes, it might be helpful. And I'm hearing a March date, but maybe having activities that were targeted at that date and getting prepared to have that information. So elected officials, school districts all have weekly newsletters. Universities have all letters. I mean, you look at your large employers in the state of California and just make a list. So I would venture to say that that libraries have their cities all have newsletters. They have all commissions. This needs to be a more targeted, unified.
So I'm happy to say,
plan.
Ms. Yaroslavsky, that everything you've stated is in our current plan. So
That's
there's-
good. I must have missed it.
Yeah, we talk about school districts, we talk about legislative offices and getting to them. A lot of the legislators right now are doing Twitter, which, for the younger generation.
They're
that
also
seems to be-
doing
and they
newslet- they're
do-
doing-
And they do newsletters,
I
yeah.
get them, I
So
know.
that would be the ones that we're reaching out to.
And just so you know, I've done a couple meetings lately with, they're on the break right now, but everyone I've met with, I brought this up and just said we really need their help and that we're kind of coinciding with another legislative day, and everyone seems eager to participate, so.
Yeah, but it means handing people a camera-ready opportunity to print and reprint. So it's more than the phone conversation, it's more than the meeting, it's meaning being ready to deliver.
Agree. And in addition, I also partner up with California State Bar and legislators, and we do outreach. And we did a couple weeks ago in Yolo County with the district attorneys and along with their representatives. And so we do that as well. I agree, that's a great avenue, and we do take advantage of it.
So again,
Dr. Levine.
Again, this is an impressive list of tactics. And I think based on your comments, there probably needs to be, it would be helpful to have a process that prioritizes which are the most important and most impactful, rather than, any other method of going through that list. I have a couple of questions. The word verify, I'm not sure how meaningful that word is to a lot of people. It almost sounds like a command, verify a license. And is this going to be available in Spanish, the materials?
That's what we're working on. We have an individual in our office. We can do Spanish. It will be probably difficult to do a lot more other languages, but definitely we can do it in Spanish. And just so you know where the Verify a License comes from, that's the button that's actually on our web page where you go to check the license, and that's where we've brought that from. Yeah.
Which raises the question, is that the best language to have on the button? I mean, again, it's a vocabulary issue, and whether it's a 12th grade or an 8th grade vocabulary, and whether it's eye-catching to the people who perhaps are most in need of this. And the other, and again, I mean this only in the most positive way, it doesn't tell me what to do with the information I find. So it provides no context about discipline. It doesn't even refer me to a place or a set of actions I can take to understand what I'm going to see on the website. And so we can direct a lot of people to the Verify a License button if they have questions, if they have concerns. Is there some context we can create as to what this means?
And I think our hope is that once we get because there's two things we're doing, one is the PSA to put out there, like Ms. Yaroslavsky talked about, something ready for individuals to use that will bring individuals in. But then there's the tutorial, and that's really what we would like to have on there, because then we need to go through each item and say, what is an accusation, what is a decision, what are these, and what is available on the web page? Because I know we got some questions, well, what's available out there, and to talk about, what it lists out there, the status and the education of a physician, and then any action that's been taken, as well as where they're located. All of the physician survey information is on the profile as well.
Right, and how many Smith, John, how do you find your physician among the
multiple?
We can't find them, so I don't know how
Yes.
public's going to find them.
Even adding a simple, if you have questions about the information that you find, be sure to ask your physician at the next visit, or something like that. That gives me a place to go if I find the whole thing
Right.
too confusing.
And refer them back to the board.
You guys know the medical board, we know the medical board.
Right.
The public's not as aware of the medical board, so you have to look at this from the framework of someone who might not be as experienced. So asking the question, whether the doctor is licensed or not, we assume the doctor might be licensed. Let's hope. But checking the license to make sure that if there's discipline against the license, you're at least making an informed decision.
Right.
So just simple English language or Spanish, Korean, whatever you want to put it in, but simple terms for people that are not as familiar with the process as we are.
And as far as the Verify license, we have kind of put this forward, after we've had the brochure and everything. We're amenable to change. We'd have to, take our brochures that we've used and use them, but we just need input as to maybe what you would think a better word than Verify if you have one, or we can do a focus group or.
I would test it before discarding it,
Okay.
I guess is what I'm
Okay.
saying. I'm not saying throw it out, I'm saying, do we know that this is
It
actually
works.
going to
Okay.
accomplish it?
Okay, Dr. Kraus?
I think this is great, and I commend the outreach effort. And I like that it says verify, because if it said something easier to understand, nobody would open it. And I view this really as an introduction to the website. And I think we do need to drive people to the website, and once they get there, they'll explore it, and they'll learn more about the medical board and what better outreach is there. But I think you also understand that every member of the committee and the board is willing to help and engineer these things going forward. But I think this is a great start. Thank you.
And can I just, it's interesting, putting the two comments together. Maybe what we do is from the website, so we bring them to the website, but rather than, we can have two, check your doctor now, or find out more information on the Verify. And then that's when we go into more information about what each of the items mean, what the website has, what it contains, and what you can get from that information. So maybe marrying the two issues together. I think that's actually do you see what I'm saying? Like have you can go there and you can check because some people aren't going to want to read. That's what we find, a lot of people want to go right to checking their doctor, and others want to be informed and know the most information. And we have consumer groups, in the audience right now that we can work with as to, what information would you want to see on there? What would we post? So I think that would be an option, kind of what you're going to drive. Once we get them to the website, what information do they need to see once they're there?
And just one other comment, and I don't know how to incorporate it or where, but something that communicates clearly what information there is on the website about the physician and what information isn't there. So here's what you will find when you check. And for other information, please check with your physician.
And we have that right now.
Okay.
I think it's just now putting it all together, because we have, all the information that's public, and then we go into, complaints aren't public and misdemeanors are in this state and everything. So it's maybe putting it in one spot with it all together. Is that kind of what you're talking about,
Well,
Dr.
I was
Levine?
thinking more like, board certification or the things that are not mandatory and that are not captured fully for every doctor in the state.
And we do have that on there, the board certification, we just need to also drive them to ABMS website too, yeah.
This is a huge list of deliverables. I commend you for coming up with this extensive list. I think you're going to reach a lot of people. But do you have the staffing to to carry this through? Because I look at this, and I wonder if, if you need to more prioritize the big ticket items, because I see Cassandra and maybe another person, and, we do have board members that can help you or participate, so call on us, but how are you going to accomplish all this?
As I told Cassandra one day, this is going to take a team effort. It's definitely not something that we're going to be able to have, just Cassandra do on her own. We're going to have Jennifer assisting in that, as well as Cassandra's staff and other, like I said, with a lot of the events, we're going to have individuals out in other areas that can do this, because we can't travel to do that. So we'll have to use our probation unit, and then, like the last thing I said was, we have to have board members being willing to assist as well if we go out to events, so.
Yes.
And I think everybody's been
I think
willing to
please
be-
call upon us to help you. I think you'll find a willing group here. Thank you. I do have comments from the audience. So if there's no other comments from board members, I'll take the public comments. Edward Barrera, you had 4 and 5, so 4 and 5, got it.
I'll be quick. First of all, thank you very much. Verify, I'm sorry, go back. Edward Barrera from Consumer Watchdog. I also noticed the Verify Your License. I don't think it's a very clear button. First of all, I think what the staff is doing, I think is awesome. We completely support any kind of outreach, and certainly, and I've done outreach in my past, and, it's very thorough. There's two suggestions, and I think it was brought up. It needs to be in different languages. I know there's probably, obviously financial concerns, which, you would have to deal with, but I think it's incredibly important. With the explosion in Medi-Cal in the state of California, you're getting a lot of, second English language learners. You're getting a lot of people who have never, who have very rarely been able to access health care. And I think it's really important to be able to do it in, several languages. And the reality is it's also different cultural contexts. There's obviously there's a wide connection with, someone like me on Twitter, but you may not get that in, different cultures. So, please explore that. I have 2 other things. One is a suggestion. I think the website, the Verify Your License, it's really wonky. It's not a great, and I know it was foisted on you. And from what I understand, your previous website, your previous access was actually much better than what it is today. So I encourage you to try to push the state to make your Verify Your License much better. The search function is awful. If you put a name in, once again, John Smith, or if you misspell a name, if you do it in Google, they'll give you a suggestion. It won't happen here. And there's so many different, so many different names, so many different cultures, once again, when it comes to doctors. And then the other thing, it's a slight concern. I know that there's a push, and I know the full board will be talking about this tomorrow, about probation and notifying doctors. I hope this is not being considered to replace the idea that doctors need to notify their patients about probation. Anyway, thank you.
Thank you for your comments. The next speaker is Lisa McGiffert.
Thank you. I'm Lisa McGiffert, the Director of Consumers Union Safe Patient Project, and we commend the board for this outreach plan to educate the public, and we look forward to working with you and helping you with getting the word out. These educational efforts need to be incorporated in your daily work. This shouldn't be a one-time campaign. This should be integrated, and you should think about ways that you can integrate it in your regular work. And And I agree with some of the things that some of the board members have suggested to, explain to people what information am I looking for. That's very important. I also hope that this is not seen as a substitute for the petition that we've put forth to get physicians to tell their patients that they're on probation. Those patients are the ones that most efficiently and effectively can be reached by their own doctors. I see one of your biggest hurdles is that most people don't know who the medical board is and what you do. And we've done some polling in the past relating to hospitals and found that people don't know where to file complaints with hospitals, and I'm sure the case is similar to with doctors. I agree with some of the comments about taking a different approach and using more plain language. Verify a license doesn't work for most people. Use language like look up your doctor, check out your doctor's background. And that kind of information would be much more effective. And that should be on your website as well as in your materials. And this is very common in other states. They use this verify a license, and we don't like it much. Another comment is that your website has a link to something called public documents. That links to all your orders. You could easily change that to be more clear to patients. It says something like, disciplinary actions taken by the board or something like that. And that is a very quick way to look up to see if your doctor is under some kind of order. We encourage you to set some standards, like set some kind of baselines, check your website hits, and maybe do a survey and see how many people in California know about the medical board. There are surveys that are done pretty regularly, and I bet you could get a question in them without much cost. So I would encourage you to do that so you can actually see your progress over time. I know you've talked about budget. We've got some ideas about low-budget ways that you might be able to reach people. We encourage you to use social media and Twitter and Facebook. This is where people are. Use graphics that gets attention. And also provide direct information about doctors who have been disciplined. People need to understand why this is important to them. They might not understand that. The other thing is the sign that's in every doctor's office.
Please
it does
conclude.
not inform people what they need to know. It doesn't say you can take complaints. It doesn't say where to complain and what you do. So you can change that sign, and I would encourage you to do that. Thank you.
Thank you for your comments. I have next speaker is Ray Gerlich.
Hi, I'm Ray Gerlich. I'm with Consumers Union Safe Patient Project. I'm one of the members of the California Safe Patient Network. As Lisa McGifford just said, we commend the board on this Verify a License program, and some of my fellow advocates and I were across the street today, and I really want to commend you. Some of your workers came up to us, and we really liked the brochure. It was very impressive, and we appreciate your efforts. But we want to make a point that once patients get to your website, that the documentation regarding physician discipline is often difficult to read and to understand. The National Institute of Health and even Medicare recommends that public reading materials be kept at a 6th grade level. And because this documentation is so difficult for some people to really digest, we recommend that the board create perhaps a brief summary in plain language for each disciplined physician on your website to describe a history of the violations, a description of them, and the license restriction of these physicians, and a timeline for their probation so that people will understand what's going on when they get to your website. You could have a place on your website where these summaries are aggregated and update those summaries on a monthly basis. Also, according to a Pew Research Center U.S. analysis, seniors, who are the most likely to seek health care in this country, are also the group most likely to say that they never go online. About 4 in 10 adults 65 and over about 39%, don't use the internet. Only 1 in 5 African Americans and 18% of Hispanics and 5% of English-speaking Asian Americans don't use the internet. So we recommend that the board particularly target this segment of our population of healthcare patients. Maybe enlist community-based organizations and others to reach out to these most in-need patients for, to give them access to this very important information as well. So then the last thing is just to, again, translate all of this very essential information into other languages. There are so many Spanish-speaking healthcare consumers and so many other languages spoken in this state. We want to reach all of the consumers in California. Thank you so much.
Thank you very much for your comments. My next speaker is Marion Hollingsworth.
Good afternoon. My name is Marion Hollingsworth, and I am a member of the Consumers Union Safe Patient Project. Last week, the Medical Board issued a press release encouraging all consumers to consult the board's website regarding their doctors. There were 2 numbers for consumers to call for help if they didn't have a computer. I'm here to tell you that the call-in system is unreliable. As an advocate, I thought I would try these numbers. I will say the non-800 number is easier to use. The first time I left a message for a call back, and I received a call 21 hours later. I gave the employee the name this doctor goes by in his practice. I spelled it out for her and waited while she looked it up. She quickly said she couldn't find it. When I asked her to recheck, she reiterated that the name was not on the website and hung up. A couple of days later, I tried again using the other number. Again, the employee could not find the name, so she put me on hold. After 10 minutes, a recording came on asking for the medical license number, which I didn't have, and it's not found on the website or online. I left a message but was never called back. Now, I have to admit, I did test these people. I knew this doctor uses his middle name in his practice, but that he goes by his first name on the medical board license. And that middle name is spelled differently on Breeze than he tells his patients. To find him, you have to look up his last name and scroll through several pages guessing what his name is. It's very confusing to patients, but it's very clever on the doctor's part. You see, any doctor with any slight deviation in the spelling or use of his name cannot be easily found on Breeze. This not only fools the public, but apparently also medical board employees. Now, the doctor is not the only one who uses a different name with the board than he does with his practice. I can give you names as well of others who do this. Now, it would be good for his patients to know about his history because he does have 1 discipline and 1 accusation on his record. Oh, and by the way, one time when I called, I was told that Breeze is not for public use to look up a doctor, but it's for doctors to change their records. So I don't know what happened there. I did go to Horton Plaza to check out your info table. I went there yesterday at 2:30, but you were gone, and I thought you were there from 11 to 3. I guess I got my information wrong. Today, employees are very helpful, and of course, you did find the doctor I was looking for, but the internet connection was very spotty, so the on-site locations might have to work with that. The bottom line is the call-in system is no more effective than the Breeze website itself. The only reliable way for consumers to truly be informed is for the medical board to require doctors to tell their own patients of their status themselves, whether they're in good standing or whether they're on probation. It's much cheaper and much more effective. Thank you.
Thank you for your comments. My next speaker is Yvonne Chung.
Good afternoon, Yvonne Chung with the California Medical Board. CMA does support efforts to help patients to become more informed. We also have some concerns regarding understanding terms on the website. For example, in terms of if you're going to be directing patients to the website, you're going to need a lot more explanation about what the various statuses mean, because by my count, I think there are 7 or 8 different statuses where a physician is no longer practicing, and ranging from canceled, surrendered, inactive, all of which sort of have a negative connotation, but not all of them are related to disciplines. So I think that will have to be fleshed out and taking another look at how those terms are used, and whether or not, explaining what their disciplinary action was for, if it was related to patient care. I don't know if patients are interested if their physician has failed to pay their taxes last year and has a suspension for that, but I think it should be made clear. And if this is going to be a campaign that is going to be sponsored by DCA, you might want to think about adding other professions to this as well, because as you know, physicians are not the only ones who have licenses. They have other practitioners in their practices as well. And I think a lot of patients probably don't even know if they are being seen by a nurse practitioner or an MD or a DO. It's unclear if a DO would show up. They're not regulated by you either. So, what we do is when we get calls from patients asking about their dog, we encourage them to have a dialogue with their physician if they have concerns, and you may want to include similar language. And we're looking forward to participating in your stakeholder group meeting. Thank you.
Thank you very much for your comments. Any other comments from members in the audience? Any comments from those on the telephone?
Hello, Amber. Any calls on the phone?
Yes, we do. One moment.
Okay. Go ahead.
This is Dr. Gill, Kenward Gill. I'm calling from Fresno, California. And this
You may have to turn up your volume just a little bit for us, please.
Hello, is it audible to you guys?
Yes, that's fine. Thank you.
Okay, I'm calling from Fresno, California, and this pertains to some of the speakers have already mentioned is some of the doctors don't use full legal name, and that poses challenges even in terms of communicating between the physicians. So I would encourage the board to notify the physician the need to use the full legal name and avoid confusion that exists. And the second thing I wanted to talk about the BREEZE system, that DOs are also licensed, and the BREEZE system sometimes does not cross-populate even the fictitious names and the names of the people, some of the doctors. So BREEZE is not a fully effective way of searching for names or fictitious name. And I've done some research and spoken to people who handle the fictitious name permit in the medical board, and they've also expressed the same thing, that the osteopathic board does not really report the same information as medical board does. So I feel the system is not foolproof. Even the DocInfo website that was recently launched is full of errors. In fact, a physician that has been shown as active practitioner has his practice actually stopped by the board. There was a cease to practice order sent over by the board, and he's still shown active. So those are the things, the various areas, various avenues where you verify physician information, and none of those seem to be universally accessible, or none of those shows the information to be accurate. So if something can be done about that, I'll greatly appreciate it. Thank you.
Thank you for your comments. Do we have anybody else on the telephone wishing to make a comment?
Yes, we do.
Okay, go ahead.
Hi, this is Susan Chinese. Can you hear me?
You might have to turn up just a little bit, or the audio just has to be turned up slight bit. Try again.
Okay. Can you hear me now?
Oh, that's perfect, thank you.
Okay, great. Thank you. I just have a question for you, mostly, that I'd like you to think about. When I look it up, quite a few good sources say that California has over 200 different languages spoken here. People with over 200 different languages, including the refugees that we welcome. So I'm wondering, when a person calls in to ask about their doctor, instead of looking them online, and they get a recording, and there's no translation service, how is this going to help all of these different nationalities and languages? That's just my question. Thank you.
Okay, well, thank you for your comments. Staff has recorded your comments. Okay, thank you very much. Anybody else on the telephone that I've missed?
None at this time.
Okay, have I omitted anybody in the audience? And now I go back to my fellow board members for any other additional comments. Dr. Levine.
So you have to look pretty hard on this to find the website. I think I'm not saying discard these, but next version, you need the website address prominently on the front. It's on, to be honest, it's on the back, hidden in small print below the mission of the medical board. And I looked a couple times to be sure I wasn't missing it, but
It's on the front.
Any other comments from members of the committee? Yeah, also, this is a very busy brochure. So I'm, with my bifocals, I'm trying to look at it, but it might be a little busy, but, and one question, if a patient's doctor is a DO, does the website say to them, well, if you can't find it, make sure the doctor's not a osteopath?
We do. We have that on the page where you first hit when you go in to read that information, that
Oh, that's
they
good.
could be listed as an osteopathic physician too. But
there
if
are
they
many,
don't read that, then they won't know. If the one thing is, if they go in from the Breeze webpage straight into Breeze rather than
Right.
through our webpage, when they look up the last name, if they just do it by last name, it'll pull up the physician whether they're an MD or a DO. So
Okay, because a lot of patients sometimes don't
Yeah,
know
they
the
get confused
distinction, and they keep saying, oh, I can't find it, and they're with the DO board, so it's different.
Right.
Thank you.
So one thing I don't think I saw on the list of so many things that you were going to contact is that there, in California, there's so many organizations that support ethnic minorities, community health groups. They're nonprofits. They're there to help bridge roads between the community and the providers, in not only for doctors, but other health providers or other rent control or for housing uses. And I would suggest that you engage some of them as your community stakeholders, because then they can also help with translation and also to disseminate the information. That I think that they can be really very good partners with what you're trying to get done.
Thank you. Any other comments from members of the committee? Seeing none, do I have a motion regarding this plan? You need a motion?
I don't know. Yeah. I think you.
What do you want? What do you think, Carrie?
can I make a request to staff? How would that be?
Sounds like a good idea.
Would you like it?
First, to commend all of you, the three of you and the folks who support you, for what is a very ambitious effort to truly cover the waterfront. And I think it would be helpful for the committee at our next board meeting, at the next committee meeting, to see perhaps a refined set of next steps and for my purposes, a prioritization of high impact, likely high impact, high volume points of contact, so that you know we can be comfortable that you are stewarding your own resources in ways that are going to have the impact that you want and that represent the quality of the work you're doing.
And I think the comments don't really detract from your work. I mean, they're all constructive, so I think we all appreciate the amount of effort. I mean, it's stellar work. So we just give suggestions, so please don't take it as criticism. But for the future, like Dr. Levine says, if you can prioritize your plan, your deliverables, because there is an impact on staff, so we have to be cognizant of that. So, thank you very much. Anybody else?
I'll move to adjourn.
We're not
Wait,
done.
no, we have the next and last, I know, the last agenda item is future agenda items. Do I have any comments from board members regarding future agenda items? None. Do I have any comments from the public regarding future agenda items? I do not have any speaker slip. I don't want to leave anybody out. Dr. Hawkins.
Just follow up on the demographic study. Would that be in this our committee?
it's for the enforcement committee.
It's the enforcement committee. Right, I know, we get
Which has now 20.
confused, it's changing names. Any comments on future agenda items on the telephone?
Any callers on the phone, Amber? Amber, can you
We
hear
do
me?
have one at this time.
We have one comment? Is that what you said?
Well,
Go ahead.
This is Dr. Canver Gill. I'm calling from Fresno, California. I wanted board to consider putting foundational models of practice in medicine in state of California, especially after the 2009 Affordable Care Act. We've seen a lot of bundled payments coming in and hospitals gaining a lot of control on the way the physicians practice medicine. I'm not sure if the enforcement meeting has already happened. I wanted to bring a case, a couple of cases for the enforcement to look at the pattern that's going on. So it will be a good idea to have a discussion on the foundation, non-profit foundation, 1206L, and the way they practice medicine in the state of California and the role of hospitals and the line that is being crossed so many times in regards to those. So if you could have that and corporate practice of medicine somehow talked about all over again, I'll really appreciate it. Thank you.
Thank you for your comment. Any additional comments from anybody on the telephone?
We will take our next one.
We have an additional comment. Okay, go ahead, please. You may speak now. Can you hear us?
Carol, your line is open.
Yes, we can hear you. Go ahead. Go ahead, we can hear you. Go ahead. Oh, we just heard the
There
operator.
is no response from this person.
No response? Okay. Anybody else on the telephone?
No persons at this time.
Okay, thank you very much. Now do I have a motion to adjourn? Oh, you don't need a motion. Meeting is over. Thank you. Thank you very much for your attention.